The cholesterol treatment trialist is a large meta-analysis group, and they also looked at what was the benefit in the use of high-dose statin therapy. First, they looked at 5 trials where they used high-dose versus low-dose of statin, and they found that there was a decrease in any major coronary events. There was a decrease in coronary revascularization. They found that there was a decrease in stroke, and this is in 170,000 patients, and that any major vascular event was also improved. In this particular group of 21 trials, they compared statins to control, and they also found that coronary events were decreased, coronary revascularization was decreased, stroke was decreased, and all vascular events were also decreased. So in 170,000 patients, they say that the use of statins in primary prevention are effective. However, let's look at death from vascular disease. Cardiac death was decreased, but the death rate from stroke was not. And if you remember my prior slide, many times people who have stroke, although they die, they don't die from the stroke. They're more likely to die from another form of vascular disease. If you look at non-vascular causes, because we're always concerned that perhaps by treating somebody's cholesterol, we may increase the incidence of cancer. They found that any non-vascular death was not increased, and any death altogether was also not increased. Well, strokes come in different varieties. We talked about hemorrhagic strokes. We talked about ischemic strokes. And about 80% of the strokes are due to ischemia, and that can be due to large artery atherosclerosis, cardioembolism, small vessel occlusion, stroke of other determined etiology, and about 20 to 30% of strokes are undetermined etiology. Although they're not really undetermined, we just hadn't dug deep enough to really look for other reasons. So this is a MRA of the right internal carotid artery, and you can see at the arrow there is an obstruction, but it doesn't look like it is flow limiting. And if you go further, and I'm not an expert on MRI, but somehow they change what they're looking at, and they can actually, and maybe Lee can wax poetic on this, they can actually determine whether the plaque had a hemorrhage. And this plaque, although non-obstructive, did have evidence of hemorrhage. Starting in coronary artery disease, we determined that there were 8 different types of atherosclerotic plaques. And the one that is most common in acute coronary syndrome is the type 6 plaque. And it is characterized by a lesion with a surface defect. It can have a hematoma or hemorrhage, and there may also be a thrombotic deposit, as opposed to old over-the-hill kind of plaques that are either calcific or fibrotic. These plaques, at least in the coronary system, cause effort-induced angina, but they generally don't present with an acute MI or an acute coronary syndrome, while these type of lesions are the cause of acute MIs and acute coronary syndrome. If you actually look at a group of people who were symptomatic and went through the MRI and MRA, a large percentage of them actually had a type 6 atherosclerotic plaque, and this was characterized by both hemorrhage or rupture or thrombus formation. And although I didn't point it out, a large percentage of the patients also had type 4 or type 5, which, although they don't have hemorrhage, rupture, or thrombus, are the type of plaques that will go on to develop those complications because of a large lipid burden within the plaque. These, again, are MRIs and MRAs, and you can see in the first slide that there's actually disruption or a plaque rupture. On the second slide, you can see the formation of thrombus. And on the third slide, that's a representation of intraplaque hemorrhage. So in this one particular group of people, they were able to define by MRI and MRA the characteristics of people with acute strokes or TIAs. Similarly, there were a group of people who had type 4 and type 5 lesions where there was a large lipid-rich burden within the plaque. It's kind of interesting. I took this from a presentation I've given many times on atherosclerosis and the coronary artery disease. You can see that this dates back to 2002. So perhaps, as expected, cardiologists knew more than neurologists, and we were attuned to subclinical atherosclerosis many years ago. We divided people into vulnerable plaques. These are plaques that are likely to rupture and cause an acute coronary syndrome, but you can see from the prior slides that the same thing goes on in the cerebral vascular system. And these are characterized by a thin fibrous plaque covering, a large lipid pool, inflammatory cells, and few smooth muscle cells. And in cardiology, and similarly, hopefully in neurology, we do the same thing. We try to take a vulnerable plaque and convert it to a stable plaque, and we do this by allowing the plaque to mature so that the fibrous cap becomes thick. You get rid of the lipids within the plaque, you decrease inflammation, and you increase the use of dense extracellular matrix. Well, does that really happen in the cerebral vascular system? Again, this is an MRI of somebody who presented with a stroke, and you can see in the two green enclosures that there is, pointed out by the yellow arrows, a large burden of lipid. And after treatment for 3 years with lipid-lowering therapy, you can see that the burden of lipid deposition significantly decreased, and a follow-up in 3 years. So again, showing that you can actually stabilize and, if you will, reverse atherosclerosis in the cerebral vascular system. It's hard to use this technology on the heart because the heart is moving, and it's hard to get a good visual impression as to what's going on with the arteries of the heart. But with the cerebral vascular system, it's much more accessible. If you actually look at the volume of lipids within the atherosclerotic plaque, it goes down significantly. And also, if you look at the percentage of the plaque that is composed of lipid, it also goes down. Large lipid burden, smaller lipid burden over a period of time with treatment. Similarly, if you look at loose matrix and calcium within the plaque, that stays the same. And if you look at the percentage of fibrous tissue, although the volume goes down, the plaque is more likely to have a larger burden of fibrous. Again, taking an unstable plaque and making it stable with the use of lipid-lowering therapy. So what are the guidelines for primary prevention of stroke? In addition to therapeutic lifestyle changes, treatment with an HMG-CoA reductase inhibitor or a statin is recommended for the primary prevention of ischemic stroke, and that's considered Class 1 level of evidence A. Similarly, if you look at secondary prevention, statin therapy with intensive lipid-lowering effects is recommended to reduce risk of stroke and cardiovascular events among patients with ischemic stroke or TIA, and they said that the LDL cholesterol had to be greater than 100. That was Class 1 level of evidence B, and revised recommendation is 2011 versus this, which is 2014. They went also on to say that even if your LDL cholesterol was less than 100, that was a Class 1 recommendation, but there's not a lot of evidence to substantiate that, and it's really a bunch of experts that feel that, and that was a new recommendation. And then patients with ischemic stroke or TIA and other comorbid cardiovascular problems will be treated by the 2013 recommendations, which I will review with you. So I think these are pretty strong statements that basically say that lowering cholesterol is important for primary prevention, and it's important for secondary prevention of people who have ischemic as opposed to hemorrhagic strokes. Well, how does one decide initially to treat somebody for primary prevention? This is the risk calculator that you can get as an app on your phone. Just look up ASCVD risk calculator and it'll populate your phone, and you don't have to remember any of this. But it's a way to approach a particular problem. This includes stroke. So the original risk calculator, which was based upon the Framingham study, did not include stroke in the population of people. These people are not the same population as Framingham, which were middle-class white people. These are NIH populations that included Latinos and African Americans. The Latino population and the Asian population was actually underrepresented, but it did have its appropriate mixture of African Americans. And again, it included stroke because in women, stroke is a more common manifestation of atherosclerosis than is perhaps coronary disease. So it's an important thing to remember. So what do you put in? You put in your gender, you put in your age, you put in your race, whether you're on hypertension treatment, what your systolic blood pressure is, whether you're a smoker, and whether you're a diabetic. Now, this gives you two numbers, and it's important. You can be 20-year-old with a strong family history, hypertension, diabetes, smoke, and the chances of you having a coronary event or a vascular event in the next 10 years is very low because the major determinant of the event in the next 10 years is your age. So this particular calculator, I forgot you put in your total cholesterol and HDL, gives you a 10-year risk, and for people under the age of 50, it also gives you a lifetime risk. Again, that 20-year-old person with all those comorbidities would likely benefit for treatment of all the comorbidities, but we're not going to have a study that's going to last long enough to show that treating a 20-year-old is going to be effective in decreasing vascular events. So this is kind of an algorithm to follow. We talked about, first of all, calculating the 10-year risk and also lifetime risk in people over the age of 21. It's recommended that children be screened for hyperlipidemia now at age 8 because they actually use statins in children who are adolescents. Of course, many of these kids may have hyperlipidemia based upon the fact of the growing population of children with obesity and diabetes, but really what we're looking for are people with familial hypercholesterolemia. If you have some form of clinical vascular disease or your LDL cholesterol is greater than 190, the recommendation is for high-intensity statin therapy. The reason that they've chosen an LDL cholesterol of greater than 190 is that a certain percentage of these people will actually have FH, familial hypercholesterolemia. So there's a difference between a 40-year-old man that comes into your office who's had normal lipids his entire life, but now decides that he's going to eat anything and everything he wants, and he gains weight, and he's got an LDL cholesterol of 190, compared to a child who has their vascular system marinating, if you will, in LDL cholesterol from the day that they're born. So in order to draw attention to that, they have defined LDL cholesterol greater than 190. All of these people do not have FH, but a significant percentage will. For those people that don't fit into that category, if you're a diabetic, they also suggest that you calculate your 10-year risk. And to me, this does not make a lot of sense, but I don't write the guidelines. And if you have a risk of less than 7.5%, you use moderate intensity statin therapy. If you have a risk of greater than 7.5%, they suggest you use high intensity statin therapy. Now, this is based upon the fact that the guideline writers required evidence-based studies to show that what their recommendations were beneficial. Most cardiologists don't make a distinction between moderate and high-intensity statins. Most cardiologists and most lipidologists believe that the lower your cholesterol, the better off you are. There have been good studies to show, at least in coronary arteries, that you develop plaque regression when your LDL cholesterol is less than 70. And there's been no studies to show that LDLs in the 40 and 50 range are actually detrimental. In fact, when you're born, your LDL cholesterol is about 40. One would expect, since there's a great deal of growth that are occurring that time, if your body really needed LDL cholesterol as opposed to intracellular cholesterol, that God would have given you a higher LDL cholesterol. Similarly, if you're not a diabetic, calculate your 10-year risk, and if you're greater than 7.5%, this says moderate to high-intensity statin therapy. So what is high-intensity statin therapy? That is a statin that will lower your LDL cholesterol by 50%, and it includes atorvastatin and rosuvastatin, and moderate intensity will lower your cholesterol by 30 to 50%. Now, again, these recommendations required evidence-based, and most people that were entered into studies for the treatment of hypercholesterolemia, they were not treated to a target. They were treated by a specific drug, and therefore that's how the guidelines were written, not to a target, but by a specific drug.